Classifying pulmonary embolisms by clot size, labeling them as massive or submassive, is no longer the clinical standard. The 2026 guidelines replace anatomical measurements with a physiological focus. Triage is now based entirely on how the clot impacts the right ventricle. This three-step triage map classifies patients into categories A through E. Step 1 is hemodynamics, dividing patients into normal vitals versus shock. Step 2 screens symptoms. Stable asymptomatic patients land in categories A or B, typically discharged on oral anticoagulants. However, if a patient with stable vitals presents with high severity scores, you must look deeper. A normal blood pressure simply pushes the patient to step 3 to look for organ stress. Step 3 focuses on organ stress, where the right ventricle is our primary target for investigation. This slide details the specific evidence required to prove right ventricular stress. You need imaging, specifically an echo showing an RV to LV ratio greater than 0.9, and you must check for elevated troponin or BNP. These two metrics define category C. This slide breaks down the intermediate risk bucket, which relies entirely on your echo and biomarker results to subdivide patients. C1 means both imaging and biomarkers are completely normal. C2 is an or condition, meaning either the echo is abnormal or the biomarkers are elevated. These patients require closer clinical monitoring. Category C3 carries a much higher risk. Notice the text here. This is an and condition. The patient has both abnormal right ventricle imaging and elevated biomarkers. The distinction between that or in C2 and the and in C3 dictates the entire care plan. It determines whether a patient safely stays on a standard ward or requires high-level intervention to prevent sudden deterioration. Returning to our initial fork in the road, let's look at the patients with low hemodynamics.
This graphic introduces category D, incipient failure. D1 is defined as transient hypotension that responds to initial fluids. D2 covers normotensive shock, where blood pressure looks acceptable but perfusion is poor. Both states represent the crucial window just before complete cardiovascular collapse. Let's test this algorithm. Your patient has a normal blood pressure of 120/80. Their echo shows an RV to LV ratio of 1.1, and their troponin is high. Where do they belong? Because their blood pressure is normal, you completely bypass the D and E tracks. But since they have both a positive echo and positive biomarkers, they land squarely in category C3. If you skip this exact mental workflow, you risk letting a C3 or D1 patient slip into irreversible shock while you are falsely reassured by a stable blood pressure reading. There is an independent variable that can override this entire cardiac workflow. Severe respiratory failure can occur even if the right ventricle is perfectly stable. This slide defines the R modifier. The criteria are an oxygen saturation under 90% on room air or a respiratory rate over 30. The R modifier operates as a parallel track. You append it to the patient's existing cardiovascular score, turning a C3 into a C3R to immediately flag the need for mechanical ventilation or significant supplemental oxygen. Treating a pulmonary embolism requires scoring the heart and the lungs independently. Accurately plotting a patient on the A through E map loses its utility if you ignore their respiratory distress. This brings us to the terminal branch of the triage map, category E, established failure. E1 designates persistent cardiogenic shock despite initial support. E2 designates refractory cardiac arrest, meaning the patient requires immediate mechanical support. This table maps the completed A through E categories directly to their mandated clinical settings and initial therapies. Low-risk patients get oral anticoagulants. Category C requires low molecular weight apron or PERT consultations, and Category E mandates systemic lysis or ECMO. Surviving the acute triage phase, however, is only the beginning of the patient's journey. This graph shows the timeline of recovery. The guidelines mandate a follow-up screening protocol lasting at least 1 year to monitor for chronic thromboembolic pulmonary disease. Pulmonary embolism management is no longer a matter of measuring a clot on a scan. By applying this rigid, physiological workflow, you secure both immediate survival and long-term lung function for your patients.